Dear colleagues, welcome to Med Revision. Today we'll be discussing nephrotic syndrome. It's defined as presence of renal disease sufficient to produce hyperproteinuria greater or equal to 3.5 grams per day. 2. Hypoproteinemia or hypoalbuminemia. 3. Edema. 4. Hyperlipidemia. And in some classifications they've included thrombosis. So let us discuss the pathophysiology of these features. Let's start with hyperproteinemia. Renal disease may cause direct or indirect damage to nephrons. Now, due to damage of the glomerular basement membrane, large molecules such as proteins and glucose can freely pass, therefore get filtered into urine, causing proteinuria. And just as an example, other large molecules, such as glucose in other instances, can also be filtered into urine, causing glucosuria and diabetic nephropathy. But in nephrotic syndrome, the most important loss via urine is proteins. 2. Hypoproteinemia, hypoalbuminemia. So, because we are losing protein via urine, that means it's decreasing in blood. So that's hypoproteinemia. Hypoalbuminemia, albumin is more specific here since it's the largest protein component of human blood. So due to rapid loss of proteins, the liver can't compensate fast enough the synthesis of new proteins to balance the loss. Thirdly, we have edema. Now, because we are losing circulating plasma proteins, there's a decrease in oncotic pressure. Oncotic pressures is an osmotic pressure exerted by proteins to reabsorb water back into the blood. Therefore, if it's low, it means fluid will not be reabsorbed into the circulation, that is, into blood, thus building up in the interstitium. And this fluid accumulation in the interstitium leads to edema. The second proposed mechanism is that, because of hypervolemia, that is a state of abnormally low extracellular fluid in the body, the kidneys become underperfused, so leading to activation of the renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system increases salt and water retention, causing the edema. Fourth, hyperlipidemia. Loss of lipoprotein markers on LDL and chylomicrons leads to them not being detected or being lysed in the system. Therefore, they increase because they cannot be cleared. They are causing the hyperlipidemia. Also, the liver increases lipoprotein synthesis to compensate for the lipids filtered into urine. Fifth, thrombosis, which is a very important one here. It is also caused by proteinuria. Let's remember that antithrombin 3, protein C and S are also proteins. Antithrombin 3 is a natural anticoagulant. Protein C and S inhibit factors eta and 5A. The S stands for activated in the coagulation cascade. Because they are low in circulation, this leads to hypercoagulable state. That means you are more prone to producing thrombi or clots in your vascular system. So let's see the history and physical examination of those features we mentioned. How do they manifest on people who have nephrotic syndrome? So, history and physical examination. These people have history of diseases that present with nephrotic syndrome, such as minimal change disease, often seen in children. So children presenting with edema. The first thing you should suspect is minimal change disease, diabetic nephropathy in diabetics, lupus nephritis in people who have lupus, and then renal amyloidosis, which is one of the exogenous deposition etiologies that cause nephrotic syndrome. We will discuss them later. So edema. How does edema present in these patients? It's described as pitting edema. That means when you press where the edema is and you lift your finger, it'll leave a hole there for a few minutes. If it's very severe, it will lead to generalized edema, called anasarca, or if it's localized, usually on the face, especially in the orbital area, so around your eyes, it may be seen on the ankles as seen in those patients that are bedridden. So when you do percussion, you'll be able to detect this edema as abnormal dull sound. Thrombosis and hypercoagulable states. It's very dangerous. Venous thrombosis are more common than arterial. DVT or deep vein thrombosis is the main manifestation of thrombosis and is often localized in the low limbs. So these patients will have a swollen leg in the affected side, rarely both legs are affected, that are painful and warm to touch. This is because of phlebitis or vein inflammation. In more severe cases, there can be inferior vena cava thrombosis or pulmonary artery thrombosis, leading to acute heart failure or pulmonary embolism respectively. Next are immunoglobulins, which are also proteins. So they too are filtered out with urine. It means that the patient will be susceptible to infections. So we should always ask about recent infections. So for diagnosis of nephrotic syndrome, the main feature of nephrotic syndrome will be high proteinuria greater than 3.5 grams per day. A single spot albumin to creatine ratio or 24-hour urine collection are diagnostic tests of choice. Renal biopsy is indicated to detect the underlying etiology. So for the actual workup of nephrotic syndrome, we first assess clinical features, so edema, thrombosis, infection. Secondly, we do urine analysis. We first do deep stick test, but remember that it just shows you the presence or absence of proteins and not the amount of protein loss. After detecting presence of proteins by deep stick test, you can follow it up with either 24-hour urine collection or single spot albumin to creatine ratio. Microscopy can also be used to analyze presence of lipoduria and is classically seen as Maltese cross under microscopy. After microscopy, a blood chemistry test is done to confirm hypoproteinemia. So we'll see decreased serum proteins, hyperlipidemia with dyslipidemia, where cholesterol, LDL and HDL and triglycerides will be abnormal. Following the above mentioned, we evaluate for secondary causes of nephrotic syndrome. So this is where we check for history of known disorders that cause nephrotic syndrome, for example, diabetes. We'll measure the glucose level, in lupus, antibody tests, and others accordingly, and if we do not find any secondary causes, renal biopsy is indicated, and this will give us the definitive cause of nephrotic syndrome. We will discuss the primary and secondary causes of nephrotic syndrome in further detail in later videos. So for management, secondary causes are treated accordingly and lifestyle modification for salt restriction and water restriction. For pharmacotherapy, diuretics are used to decrease the edema. ACE inhibitors are very important because they not only treat hypertension, but will decrease proteinuria and slow down the progression of renal disease. But it is important to remember that they do not cure the underlying cause. ARBs can be used if ACE inhibitors are contraindicated. Glucocorticoids or immunosuppressants are used in primary etiologies, which we will discuss in future videos. Thank you for your attention. I will see you in the next lecture.